So when we hear about mortality statistics, we usually hear about it in terms of when someone's born, how long are they expected to live? But what you really want to know is if I'm of a certain age now, how long am I expected to live? And that's the type of concern that people who sell annuities or actuaries worry about. So they make special tables for just this type of concern. So you can see here, this is a mortality table where the blue line is for men and the red line is for women. So if you are a male, age 70, so you would pick that out on the bottom. If you're a male, age 70, you're expected to live until age 78 for planning purposes. Now that's somewhat disappointing because we'd like to think of longer times than that, but in terms of average statistics, and we'll go into the difference between that and percentiles in a later chart, that is your expected life expectancy. Now, for women of the same age, your expected life expectancies would be in the low 80s. Now, you can see as you get to be, let's say 90, your expected life expectancy is up at 97 or 98, and that the outcomes of men and women begin to join if you are able to reach that age. So these are annuity life tables that are derived from people who collect Social Security. So even in this, you are looking at a different set of the population. You're looking at people's outcomes who have worked long enough to be able to collect Social Security.
Can I interrupt?
Yes.
Sorry to interrupt, but I believe you said for a male of 70.
Excuse me, 80.
80.
Yes, thank you. I read the long line. Well, that's worth correcting, John. Thank you very much. Yeah, that makes a better outcome for your day. Yes, 88.
Yes, it does. Thank you.
Yes, I was thinking these were every 10. So this is 85. For women would be 87. Thank you. Thank you very much, John. That was an important interruption. I appreciate it. So the real issue then becomes, as we get older, we would like to have less of these types of years where we have disability or disease and be able to live a fuller life for a longer period of time. All right, so let's see if I can do better reading the lines on the next one. It's one thing to discuss how long you live. It's another thing to talk about how many of those years are healthy. And that can vary actually quite a bit on where you happen to be born. From the perspective of maximizing your healthy life years relative to your total lifespan, Japan, South Korea, and Spain look like a good place to be. But if you are here in the United States, it's not a lot different. Again, the expected life expectancy, again, this is over people over the entire population set. Looks to be for men, John's got me on high alert here now, to be around 65 years old, and for women to be 68. Okay, so that says obviously a lot of people die before they reach middle and later years, and that's included in all of this data. But the thing I wanted to point out in this is let's look in the lighter shaded areas. For men, there's a period of just looks to be about 11 years of living with not healthy years, and for women, even a little bit longer, and that's kind of disturbing. Now, it doesn't say that those not healthy years are in the later years of your life, so we're going to push down into this a little bit more. You can certainly have a disability in non-healthy life years as a younger person. So that's over the entire population set, but I want you to keep in mind that what we are really striving for in quality of life is doing those things that maximize our healthy life years. There's another parameter that comes into play that I thought was so useful as I began digging into the information from the World Health Organization, and it's been around for a long time, started back at Harvard and then was adopted by the World Bank, which is to assign disability weights to the diseases and situations of the body that make those non-healthy life years more likely to happen. This is just a piece of a table, so it's just one small sampling, but it shows that the dementias have a significant and profound impact on the number of healthy years versus having more disability or disease-burdened years is what they call that. So it has a high weight, and this weight can range between 0 and 1. Other items that have high weight is schizophrenia, AIDS, having 20 to 60% burns over one's bodies. The concept of disease burden and healthy life years goes together to help us begin to form statistics about how long we'll stay healthy versus how long we may need help, including going into senior living facilities. So we've been looking at the population as a whole, and now there are vast tables and analyses out there that tend to segment these results by one's economic background, level of education, access to health care, your as-built environment. Do you have access to a car? Can you get to doctor's appointment? Is public transportation available for you? As well as breaking things into segments by age, by racial and ethnic makeup. And so just to emphasize a little bit more about how where you live is so important, the Centers for Disease Control has taken those weighting factors I was telling you about, the disability weights, the disease burden weights, and they have looked at how people are affected by disease and disease burden, including disabilities. You'll notice amputation of the foot was one of them, whether it came from disease or you lost it for any other reason. And it has taken by zip code and looked at the United States as to how we fare with disease burden. So when you look at these charts, the way you should look at this is that those shown here in the darkest red are carrying the highest disease burden, the highest distribution of chronic disease. So I'm going to zoom in just a little bit. And so we can see here in Wisconsin that we go from being in the lowest disease burden, that would be the lightest colors, into pockets of higher disease burden into the top of the state. The UP of Michigan, again, suffering more than the areas further down. Everyone has heard, I think, of the higher disease burden in the southern states and along Appalachia. And so this is a very interesting chart showing that what zip code you're in really matters. And if it's white, I believe it's no data. So if we go down, if we take that chart and we say, okay, I don't want to look at every graduation in color. I really want to look at the areas that are truly the best and truly the worst pockets for disease burden. We can sort of flatten out those statistics and pull out the areas where with high confidence, shown in blue, we are in an area of low disease burden. And with high confidence, shown in red, we are in an area of high disease burden. So fortunately, we can see in our area that from above Milwaukee over and including Madison down and below Chicago, disease burden is reduced, regardless of what the factors are. This doesn't tell us why. We can surmise that it involves access to healthcare facilities and higher educational attainment levels, but this does not separate those variables out. It does point out to you, though, that even in the midst of areas where there's high disease burden, near medical research centers, college towns, and things like that, you can see these healthcare islands of improved outlook. So let me get the zoom level back down to where we were. So we've talked about, and I really beat in the concept of disease burden as affecting your life and likely on average amidst the population affecting people for about a decade. So now let's look at it a different way. Let's ask ourselves, what are the chronic conditions that are prevalent, that are correlated with these high disease burdens? So these conditions themselves may not cause your life to change significantly, but they may be leading indicators or markers or conditions that are co-associated with a lifestyle that may be burdened for you. And this ranges from high hypertension, which is quite common and we'll go into, all the way over high cholesterol, obesity, arthritis, heart disease, diabetes, kidney disease, heart failure, depression, and Alzheimer's. So now you can see how we use the two types of numbers together, the prevalence statistics and the disease burden, to come up with an impact on how society is affected by specific causes of disease. For example, Alzheimer's and disease may affect 12% of persons over, Alzheimer's and other dementias may affect 12% of persons over 65. But as we saw from the other chart, the disease burden weight that they gave to it is very high. So it is more likely that this condition is going to have both a quality of life impact, financial impact, other negative impacts on your life. So I can think you can see why I didn't start with this topic as our first class. I was like going to jump into this, and I'm like, no, I think we better focus on things that form a solid firmament for us to build on for quality of life, rather than me throwing these types of numbers up. But they need to be in our mind. And so if we look at the CDC again for statistics on what percent of persons not institutionalized, so not living in a nursing home or otherwise being identified by the government as needing that level of care. If we look at those who are 65 and over, a quarter of us, just nearly a quarter, 24.3%, are in fair or poor health. So there are a lot of us struggling by. And it's funny how you think about that, because that concept, it would be interesting to know how they define it. So for example, I use a wheelchair from time to time, and I use forearm canes, and I have disability problems. Some of them are, I go through a 2-month flare up and it's really bad. Another time, I don't feel like I'm in fair or poor health, but I would be curious to know how I'm categorized by the CDC if I have those types of recurrent problems. And you're going to see that later when you get tagged as being as part of a particular population. What you perceive versus how you are identified and categorized may be different. And that's going to come particularly true as you get senior living arrangements, if that's something that you encounter in your life. Your perception of the facility is really the only thing that matters to you at that point. However, others may observe things about the facility that are not optimal for your well-being. So that's going to be a constant tension that we see in these numbers. So to identify the leading causes of death, which I've excluded COVID-19 from this, in descending order would be heart disease, followed by cancer, followed by chronic lower respiratory diseases, followed by Alzheimer's. And I like to think that's including the broader discussion of dementias as we learn more about other types, followed by accidents, diabetes, and then kidney disease. But for planning purposes, with all that background now and links to articles that I've provided, and I'm sure many of you, particularly if you've worked in healthcare, have bountiful data sources that you can go to for this information. Bottom line is, for planning purposes, 80% of those age 65 plus will require some long-term care, but 20% of us will require high-intensity care for more than 3 years. And oftentimes, high-intensity care is done by your spouse or a family member or a loved one. It doesn't necessarily mean institutional care, just that you need care for your activities of daily living. So this is a fairly standard framework that says in order to age in a healthy way, and in a healthy way, I mean extending your number of healthy years of living, like we talked about at the beginning. You need to focus on your physical health, financial empowerment, which we're going to begin to go into at the end of this briefing today, social engagement, and social engagement. If you're not muted, if you could mute yourself, we are getting some background noise in here. Just one moment. Okay. I've gone ahead and muted people right now, just because there's some background noise coming in. Oops, get back to the briefing. We, of course, need access to quality and affordable housing, care, particularly if we have progressed into needing it, and a sense of inclusiveness in our community, not being a pariah, knowing that there are people who we can meet and greet and who actually care to know that we are around and miss us if we have not been seen. This is not a course on one's physical health. I would not be the right person to teach it, but I think it has become so important. We see it in the news regularly. Our doctors will tell us, but moving, even in the smallest amount to get started, is so important for all of us. I like to combine my walks, frankly, with trying to meet other people, even if it's just going out and riding the bus. So every minute counts, and the impact on one's health is just profound. And by moving, I don't necessarily always mean walking. If you are using a mobility aid, being able to do chair yoga, being able to lift free weights, use a TheraBand and move your arms around, do things to strengthen your core. All of this are great factors in reducing risks ranging from diabetes, which looks like it takes the cake in terms of risk reduction, as well as cardiovascular disease, falls. It was funny, there's a lot of courses on falling. The Madison Senior Center has a course coming up next month to train you how to fall. Your only requirement be that you are able to get up off the floor. They use really thick, like 14-inch mats to do this, and it's intended for seniors. There's some ballroom balance classes at senior centers. There are core yoga classes on Tuesday, particularly for those who might have more difficulty doing really gentle yoga. So again, there are some options to avail yourself of in the area to reduce fall risks. Okay, and then walking, of course, and movement in general for joint back pain and even reducing risks of cancer. So it's important for the body to move to the extent it can. Okay, and Karen, I will get to your question when we get to a break. So hold that thought or put it in the chat channel. That would be a good way if anyone else has questions to put it in the chat, and I'll make sure and open that chat window when we get to a break. So the next question, if we are part of a couple, is to ask, how long will I live if my spouse passes? And that's a really interesting question, because when we go to Social Security and other actuarial tables, most of it's just based on our own individual odds of how long we will live. And so if you think about it as a statistician, the question of asking how long will one person live when they are part of a couple actually has four components, because there's four different outcomes, right? You could both be alive. You could be alive and the other one, your partner, is not. Your partner could be alive and you are not. Sorry, I didn't mean to do that. And you are not, or you could both have passed. So it isn't just a matter of adding or subtracting different probabilities. It's a combinatorial problem about how long one person will live than another one. And fortunately, there's a whole industry out there that analyzes this in great detail. And that is the industry of actuaries and people who sell annuities. So, and I'm talking about annuities that are standard annuities. You pay a certain amount and you get a certain fixed amount for life. I am not going to go into the subject of what I consider riskier annuities, things like indexed annuities and whatnot, where one is trying to beat the total return of the market. So when I use the word annuity, I mean straight, simple forward annuities of the same nature as buying a CD from a bank or buying a multi-year guarantee annuity from an insurance company. They really only care what gender are you and how long are you predicted to live. So let's go into what's called joint life expectancy. So this data is pulled from the Society of Actuaries annuity tables, and therefore it has a bias in it, because the bias is if you have enough money to buy an annuity, you may likely as a population pool be in better health. So when you look at these numbers for joint life, it's based on a population that has enough income and savings to be able to buy an annuity. So that's an important thing to realize. People who are in the business of telling you how long one person will live as part of a couple don't just look at couples individually. They look at a huge pool of people. So let's imagine when we start this analysis that we think of a pool of people, all of who are married couples 65 years old. So we're going to start with that. So as time progresses, if we were to watch this pool of people, some people may pass away earlier. Some people will pass away later. Some people will pass away in a very, very long time. So if we were to rank all those people from people who passed early to late, you would begin to develop percentiles, population distributions. You don't take averages when you're dealing with this. You start dealing with percentiles, and they are different. So let us look at this black line, which represents the 50th percentile. I'm going to say that is the expected outcome. It is not the average outcome. It is the midpoint in this pool of people, from those who die from young to very, very much later. And here is the interesting thing about joint annuity tables. And this is the thing a lot of people don't realize. And I'll cut to the message first, and then I'll try to substantiate it, which is there is a high probability one of you is going to live a lot longer than the other. And that's what the tables show. So, for example, let's go over here to this line right here, this dotted green line over the age of 78. At the age of both of them having aged, again, this pool of people we looked at who were 65 when we started, by the time 13 years have passed, it's still a 92% probability both of them will be around. Okay? Excuse me, 92% probability, this is the red line, 92% probability one or the other will be around. But there's only the 50th percentile will have both of them around. So if one had to make a statement from this, you'd say more than likely, because you're above this 50% line, both of you are going to make it to age 78. But if you were asked how many of that couple, one of them would be around, you'd say with very high probability, with 92% probability, one of you will be around. But let's go on. Let's go on for 24 years since the time we met all those couples. So they were 65 when we met them. Now we've gone on 24 years later when one or the other should be 89 years old. At 89 years old, there's still a 50% probability at least one of them is alive. But there is only an 8% probability that they both are. And so that's how you can draw this line, and why I drew these two green dotted lines on top of it, is to tell you that this is the challenge of what your fiduciary, your financial advisor will address. If you are both in reasonably good health when your advisor meets you, they are going to be trying to minimize your longevity risks. And these are what longevity risks are. These longevity risks are the fact that if both are in good health, even with that fact, there is an 18% probability that one of these people is going to make it to 95. So now imagine I drew that green line over here. I don't draw a very good straight line on the computer. I'm sorry about that. But right here, it's 18%. So it's a terrible quandary you're in when you're financial planning, because you want to maximize your spending over here in the area where you're both around and presumably in better health. But at the same time, you've got an 18% chance one of you is going to make it to 95. And then you have to plan on top of that, which is if one spouse really depends on the other, and if you work as a partnership in enjoying the quality of your life, how much money do you have to spend to preserve your quality of life during that period where there's only one of you? And I'm just emphasizing this chart so much because longevity planning is really what your financial advisor, along with many other risks that you may have in your personal life, this is in general what they are looking at addressing. So I'm not going to come back and mention joint life expectancy anymore, but when I talk about caregiving, the reason I emphasize it probably more than this set of participants in this class wanted to hear about is because I'm aware of that joint life table. And even if you don't think you want to hear about caregiving, you may be in that situation even though you did not know the risks were that high. And that's why I did include it in this presentation. So for healthy life in the United States, the real information here is on the bottom of the screen. The average life expectancy is 84.1 years. Remember, that's not the contingent life expectancy based on your current age. That is average. And the average number of healthy years is 78.9. So any one of us should plan for at least 5 to 6 years where we're going to need some extra help. And those other charts that I showed you before, based on disability light years, says it's a little bit more than that in actuality. So the reason I go through this is the transition from partner to solo living, and this also applies to solo agers now or anyone who does not have a partner, is that the rhythm of your life will change or is different than perhaps the rhythm of the people who are living as couples. You may be isolated, certainly probably are after a spouse has passed, although many folks do have strong family and support connections. You may need, if you've lost a helpmate, you may need companion or nursing aid services. You may be grieving and simply unable to act. I know with my my dear mother when she passed, it was easily a year, and with most of my friends, you know, in fact, the saying is, don't make big financial changes during that year if you can avoid it. You may have lost friends during that period when you were sick or you were caring for someone else. Paying the bills may become more challenging because of the decline in income. For example, there are many people whose spouse is receiving a pension, but that pension, there are no survivor benefits. Or they may be getting 2 Social Security checks, and when one spouse dies, the other will take the Social Security check of the higher earner, and there will only be 1 check. You'll also be in a higher tax bracket, potentially. That certainly can be offset if you have a lot of healthcare or senior living expenses. You'll be at greater risk of fraud, particularly if you're suffering any degree of either cognitive decline or loneliness. And knowing women that I have known who have been subjected to scams and have fallen for them to some degree, these were smart, bright, alert women. I blame this on loneliness and just simply having one's guard down. These are such sophisticated and well-designed fraud attempts that it's always best to assume that it could happen to you. We've talked about decline in handling day-to-day matters, and another big one, of course, is you may not be able to drive. So the ability to have transportation is going to be a driving concern for you. And then another one is having being a solo ager or having a estranged relationship with your children, and that happens for all sorts of reasons. Sometimes you will never ever understand the reason why that is happening. And so the ability to plan and execute a plan becomes more difficult. I'm going to go into caregiving just a little bit because of the results that we have from those joint life expectancy tables. It took me some time because caregiving statistics are normally given in the aggregate, but I was particularly interested in caregiving spousal caregivers. And a typical spousal caregiver is a 79-year-old female providing 34 hours of care a week at home to a male spouse with either dementia, old age, or heart disease. I got a chuckle about the word old age because my father went on for 3 to 4 years with pulmonary fibrosis and just refused to tell my mother what he had till eventually I sort of forced myself and barged into a doctor's appointment to find out what he did have, because he just called it old age the whole time. And I think that's actually very common for one spouse to try to somewhat downplay and make it easier for the other spouse to not fixate on the particular outcomes of the disease. But I thought it was interesting to see that dying of old age or telling your spouse you have old age as how you need care is not at all uncommon. The typical spousal caregiver has been doing this for 5 years, and half of those spousal caregivers are feeling some pretty acute financial strain. So it is not easy caring for one spouse. And it's funny, you can't find any pictures, and wisely so. You can't find any pictures of a senior female spouse caring for her husband on what I consider some of the most demanding tasks, which is getting people in and out of the shower, on and off the toilet, and cleaned. So this picture shows an aid, but it becomes a real challenge at that point when basic hygiene becomes an issue. So like we discussed before, It's very likely one of you will be around to age 89. There's an 18% probability one of you will be around to 95, and you may have 5 to 6 years with disability of disease when you look at the population in aggregate. When you only look at people when they get over 55, it becomes longer, closer to 10 years of disease-burdened years. So one or the other of you is likely to need mobility assistance, special accommodations, or long-term care. And as the other statistics showed, from the Boston Research Center of Retirement Studies, 20% of us, once we reach 65, may need more than 3 years of care. So it's very easy to hurt yourself caregiving. And if you are a family caregiver and on this presentation today, you probably know how easy it is to get a groin strain, back injury, or in my case, I just destroyed my foot lifting my mother. It took me a full year to get out of it. It was funny. I didn't even notice it so much until she passed, and then I couldn't walk. So it's amazing how one can push the body through real pain. I mentioned last time building those weak ties earlier, but I didn't really say as much why. If you are caring for a spouse that has dementia, your odds for yourself go up dramatically, particularly for men caring with wives who have dementia. I think it's the nature of the physical strain of it, the incredible stress, and the fact that you very much reduce your social connections oftentimes when you are caring for a spouse with dementia. So it's particularly important to try to build those weak ties now. So 60% of spousal caregivers are women, which kind of surprised me. I thought it would be a little higher, actually, but 40% are men. This was a very interesting set of results from the National Institute of Health, where they did a survey of the surviving spouse. They did a survey with the surviving spouse after a period of caregiving. And of those surviving spouses, 10% said that they considered themselves caregivers, but they were too fragile and unable to give the care themselves. So they clearly had to hire help. So 10% were too frail to caregive, even though they wanted to. Supported caregiving means that they received outside help or used an institutional facility. Solo caregiving means they did it on their own. And so if the person who recently died did not have dementia, nearly 60% of people did the caregiving on their own or with minimal help from other third parties. Men, on the other hand, tended to hire more help. And good for them. If you're able to do it, it's so incredibly demanding. But the proportion of solo caregivers is truly considerable in this country. And do we have anybody on this? If anybody was on this call, was at the presentation yesterday at the Fluno Center on innovations in aging, just let me know or put in the comments. I thought that was a particularly interesting get together yesterday at the Fluno Center, and it talked about the challenges of solo caregiving at some length. And last but not least, with the charts. I know this is a pretty analytical briefing, but it's kind of how your presenter is wired, so it's what you get. I did want to point out the real differences in caregiving that happen if you are dealing with a spouse with dementia. You're going to be spending more time preparing meals, grocery shopping. You can see the big difference here in making phone calls on behalf of your loved one, handling the medications on behalf of your loved one, and dealing with money issues. So now we're going to go into interpreting what you read and who can you trust, because when you start needing assistance, you will be bombarded with all sorts of literature extolling their good outcomes versus other choices you could make which are not so good. And in any type of presentation of information like this, where you have so much money and your quality of life's at stake, it's really important to know how rigorous is what you're hearing. And I've included a chart called Hierarchy of Scientific Evidence. It's used in the design of experiments where you're comparing one treatment against another treatment, or one treatment against a placebo. And that's what you're seeing here in this chart. But let's generalize that. Let's talk about when we're comparing one choice versus another. So case reports are when you say, here's what I've heard about choice one, Or here's what I've heard about choice 2. Those are case reports. And we can move up through a hierarchy of more rigorous studies where we begin to control for other factors, demographics. And when we get to a cohort study, which still uses observations as opposed to the design of an experiment, a cohort study is going to follow a group of people, and we try to have similar groups, and we track risk factors between the two groups. And isn't that what we really want to know when we make a decision about where we're going to live, or whether or not we hire help or we stay at home and age in place? It's like you play in your own mind. Will my outcome be better if I'm in an assisted living facility or an independent living facility where I can buy this add-on package, versus would I be better if I stayed home, retrofitted my house, and brought an in-home aide 4 hours a day, every day of the week? But there's only one of you, so you can't do a cohort study. You can't compare lots of you under this one scenario, under lots of you in the other scenario. But in an ideal world, that's the type of observational study you'd really like to see. And there are some. They're just very hard to find. Now, the reason you see very few experiments is we can't put people into senior living arrangements or not put people into senior living arrangements just the same way we assign a placebo. That's unethical. So that's why you tend to see these things top out with cohort studies. You don't go further because you can't randomly assign and do these types of blind design experiments. And the reason I'm beating this message is you're going to get bombarded with information extolling all sorts of virtues of one choice or another, and you must always question exactly where they're coming from. I'm going to just give you some examples here in a minute. What I don't want to see is see people get heavily marketed by both the in-home and long-term care and senior housing industries without you being on high alert and asking the right questions. So that's so easy to fall into. The other thing that's easy to fall into is don't worry about any of this and just wait till they haul you off and you have a medical situation, a crisis, where you have to make a decision at that time. So I do highly recommend you use those weak ties we talked about last week to talk to your friends and explore the options in your area. Get information. Information is always valuable. Try to understand where your friend is coming from when they provide this information to you and how their situation may differ from yours. The other thing is take Plato classes, talk to qualified advisors, make your choices based on your health and finances. And we're going to go just before the end of this briefing, we're going to talk a little bit about some financial criteria that you should probably think about. So using those definitions of evidence-based research, recognize most of what you're going to see in marketing literature is industry-sponsored case studies, most of it being pulled from polling data. So I'm going to assume that most of them honestly report on the results of their polling data, or like, for example, the NORC study at the University of Chicago does a good job of pulling the information from their polling data, but that is all it is, okay? It's not comparing two similar cohorts, two similar groups of people, one who went one way and one who went the other. It's not doing that. So for example, let's look at some marketing comments that are the premier talking points of the senior living community. Premier talking points. If you come live with us, you are going to, older adults become more vulnerable, but your vulnerability level off and decline shortly after moving in. Well, it probably will. But the question is, does it level off more than it would have had you hired an aide at home instead? In other words, their job is not to enlighten you on the benefits of their choice over other choices you could take. And so every time you read this literature, understand what they believe are their selling points, but always compare it against your other decision paths that you have available to you. Now, I thought this one was an interesting one. You're going to get more healthcare services here than you do at home. Well, is that a good thing? Now, the inference here, of course, is you're going to get better healthcare services here, and you're going to get it when you need it. That's the inference in all this literature. But are you getting more healthcare services there because the population is frailer? That would account for it right on its own. Are you going to get more healthcare services there because you're following more there? Are you going to get more health services there because you're receiving an unnecessary level of care? Are you getting more healthcare services because they're overbilling you, or because they're tempting you with pricey concierge services and residence offerings that you don't need? Or maybe the services are better and it's worth getting more of it and it costs more. Again, none of this is answered by saying you're going to get more healthcare services here. It could be for good reasons. It could be for bad reasons. You don't know. So I really consider this, despite how rigorous it may be in being pulled from polls, I consider most of this marketing fluff. Okay. I did like the fact that if you move into senior living, you're going to live more than 1 week longer. So, but again, there it is in the summary points from the leading research study on this. And experiencing better health outcomes, again, totally unsubstantiated. There's no cohort data here whatsoever. So when you read this stuff, read it with a jaundiced eye. Okay. And that is not to say not to use the services. I myself, for my own condition, not for my parents, have lived both in independent living and assisted living for periods of time. So when you need it, you may definitely need that level of care, but don't rely on this to convince you one way or the other. So what is the in-home care industry saying? Well, I thought that, they really focus on the fact that you're going to have a friendly and supportive caregiver. And I hope you do if you get an aide that comes into your home. The focus tends to be more on maintaining your independence because, of course, you're staying at home. And the marketing team will tell you that the main way they sell in-home care services is by telling you stories, anecdotal evidence. So I want you to know everything you're going to receive is going to be largely anecdotal, and you're going to have to make this decision on your own. Now, this chart here is going to be the subject of the whole 5th class. So I'm not going to go into it into extensive detail, but in general, the higher up on the left side you go, the more costly it is. And as you go from left to right, you're dealing with the least amount of care to the most amount of care. So if I zoom in a little bit, you're going to find end-of-life care over here on the right. And you're going to find all sorts of housing choices over here on the left, ranging from short period of time care, including adult daycare and respite care, to all sorts of housing communities. It could be a retirement community. It could be an apartment building that just likes to have people over 55 plus, 80% of the population, those active living communities. The cooperative housing arrangements, congregational arrangements, independent living arrangements. This falls under a lot of choices, again, that we'll talk more about in class 5. Then as you need more care, we're typically familiar with looking at an assisted living community, perhaps with the memory care add-on. And again, I think the term memory care should be replaced by dementia care because there are many dementias where memory is not the first affliction, where behavioral changes may occur, where you may see people with aphasias whose thinking is still pretty good, if not exactly normal, but they have difficulty articulating themselves. Under this broad umbrella, then, we have the continuous care retirement community, and this is where we often see buy-ins and other arrangements where the typical scenario is you want to move into a continuous care facility now, where you're independent, active, feel you're up to meeting new people. You're still in pretty good health because they want you to be in pretty good health at that point if you consider it. And then you can age in place there. You can receive medical services in that facility. And there's all sorts of economic models associated with continuous care facilities. And their availability really depends on where you live in this country. I will tell you personally, I love the concept, but my biggest problem with continuous care facilities or anything where you have to put down a chunk of money is that these facilities do not have credit ratings and bond ratings like from Fitch or Moody's. In other words, you don't know how fiscally strong they are without a great deal of work. And even then, you may not have enough information to make a determination because you really are putting in place quite a bit of money to support the rest of your life. And for some, it works out beautifully. For some of these communities across the country, there have been some bad financial outcomes. So again, you need to be cautious. This chart has a lot of detail. But I thought if we were talking about a quality of life, we probably ought to go into what it means just a little bit more. And again, there is a subjective perception about what you think the quality of life is versus how others might say your quality of life appears to them. So for example, you might be quite comfortable living at home, but anyone else looking at your environment might say that is an atrocious environment for your personal hygiene. Okay, you need pest control, doesn't smell well. I'm worried about you, mom, dad, grandma. So we have to deal with both axes of quality of life. And it goes across, it cuts across many facets, your physical well-being. How energetic are you? Are you relieved of pain? Do you have the tools that you need to handle movement with your disability? The next one is your psychological well-being. How do you feel? Have your emotions become flattened? Have you become unexpressive? Have you become apathetic? Or have you become only able to express negative emotions and finding no more joy in your life? And then social and environmental well-being. Do you have access to the care you need, medication you need, and access to leisure and other activities that make life worth living? So again, all of this is addressed by your ability to adapt, as well as by your socioeconomic status and availability of places to go. Again, going on in course in session number 5, we'll talk more about these living options, their choices. Of course, you can decide to stay at home, or you may be able to use other community programs to help offset the costs of some of these types of arrangements. And then you have to consider your own personal health, including your mental health and your ability to change and deal with movement into these facilities. And we're going to touch on both retrofitting your home and grief just a little bit, and then we will take a break right before the financial discussion. I do not know how many people in our session here today come from social services or counseling backgrounds. There are many, many different models of grief. That is not my field of work. But I touch on it here because one of the biggest capabilities you need in making a change to your living arrangement is your ability to adapt. And one of the models for grief is a little bit different than the other, which is if some people believe that your grief will slowly subside over time, there are others who say that the grief feels as big a hole in your heart as always, that absence and void is felt perhaps not so distressingly, but still quite acutely, but that you grow bigger around it so that you are able to add on and bring new things into your life while still acknowledging that hole in your heart. And that grief is not only the loss of another person, that grief may be a loss of a lifestyle. I mean, I'll tell you, my husband and I ballroom danced for 34 years, and when my joints finally gave up the ghost, that was a level of grief I didn't expect. I think it was because of the intimacy of what we had done together, that when I could do none of it, I mean none of it, because the decision was I'm either going to be able to walk sometimes or not, that era was gone. And it was the passing of an era. It grieved me deeply. And I'm sure other people who have been active in sports or certain lifestyle, enjoying their environments, feel that grief as well. But there is surely no greater grief than losing one you have loved intensely. And so the ability to grow around that grief and to adapt is going to be a key determinant of your ability to successfully transition into a different living arrangement. So when it comes to transitioning into a different living arrangement, one of your questions might be, well, can I do this at home where I have a better support network, or which will be financially better for me? And this senior tech industry is just becoming huge, just phenomenal. So there are types of aids, and I'll show you some pictures. There's types of new devices and out there to help you make it easier to do your activities of daily living. There's automated tools now for creating your end-of-life plans, though, again, I must add, always seek the advice of legal counsel. There are tools for helping you take your pills, for giving you technology at home to help remind you of things, to help prevent your falls, or to give you a way to get help if you do fall, and tools for social engagement. Again, there's a link down here. You'll have a copy of these charts. You can click it. There's some really interesting articles on types of technology that you can bring into your home and work with those around you to integrate into how you live. Now, here's just some examples. I actually have one of these wheelchairs. When I take this off the presentation mode, it's actually parked behind me. But it's a wheelchair that has a nose on it like a bicycle seat that lets you stand up a little bit so that you can still offload your weight by 30 to 40%. But you can move your hip joints and your knees so you can practice walking a little bit, even though you can't handle your own full weight. I thought that was really cool, and I paid that through the nose for it because I got it before it became Medicare approved, and when they were still lots, because I literally couldn't get better because I couldn't walk and I couldn't quite get to crutches, and so this really helped me. I really got better and started to heal when I had this. And this is not the only type of wheelchair development that's out there, but this is one that worked for me. There are pill dispensers that are tied to apps that give you reminders, and so that will work, assuming you still have the cognitive facilities to be able to use it. In the dementia community, this is a big one. The Echo Show has become hugely prevalent in those who are caring for a loved one and may not be in the house all the time. So if you have a loved one with mild cognitive impairment, you can put this Echo Show, and they come in different screen sizes. You can put it in your house, and you can just drop in. The person doesn't have to answer the phone. They don't need to know how to hit buttons. You can just drop in and talk to that person. You can speak through it, and they can see you. And so that's really helpful in those early and mid stages of dementia. There's what they call wearables for fall detection, new aids for getting people off toilets and out of beds. Another big one for the dementia community, and this subject is near and dear to me because I'm a caregiver. GPS trackers inside shoe soles is a big one. And so that if you have someone that wanders or likes to take walks and still may be able, or may just go out on their own and forget the rules, these can be useful devices. There's senior exercise tools and smart thermostats. That's another one that's really helpful, people. So if you've got a loved one or you yourself have trouble keeping the temperature at a certain temperature, these tools can be set up, and people can even remotely operate them. They don't have to be in your house to be able to change the temperature. And last, again, also another one popular with dementia patients is the cuddly robots, as well as people with all sorts of cognitive, grief, or mental health issues. I'm passing this on because even if you're not dealing with someone who has dementia, I have found this to be the best community of, it looks like 16,000 members are in it. Again, I've often said, don't use Facebook, but have a Facebook account so you can go to some of these groups. This is called Technology and AIDS for Dementia, but I would actually call it really cool stuff to have in your home that might help make living a little easier. And so, this page is particularly robust. You can just click the search button and find out really things you never knew existed. It's been completely eye-opening to me. And also eye-opening, I want to say, is our local Aging and Disability Resource Center of Dane County. We'll talk about this again as we move into assisted living and other services in session 5. But they are there for you to call for long-term care options and applying for public benefits. Now, can I say that they will do much more than give you literature and point you to resources? They're going to start with that. So you really have to form your questions and push for the help you need. You really need to advocate for yourself, because these types of organizations particularly tend to be lightly staffed, not staffed as much as the community really needs. So this was, again, a National Institute of Health study that said, what are the most important things that determine whether or not a transition to an assisted living facility is going to work well? And the answers and how well people did were all over the map. The most important thing is your ability to adapt. However they measured that, and whatever scale they used to be able to measure people's adaptability, your ability to be able to adapt, and I would say adapt particularly to grief, is going to be a huge one. The second one is the capacity of the facility to meet your needs. So again, another really broad umbrella of how well are they equipped to be able to deal with your unique medical and psychological needs. And that is why I'm going to take a break for just a minute, but I hope you will stick after this break to cover these other items, because we're not talking about stocks or bonds or how to make money. We're just talking about the fundamental financial concepts to be able to make choices as you age. So let me come out of this. And let me see, do we have any questions? Statistics on rural versus urban. Gretchen, only embedded in the zip code. You probably have to I mean, I know I've seen articles on this, just like we discussed food deserts, there are health deserts. But the CDC zip code and database there, if you use that link in the briefing, I think that would be a really good place to start, because that really drills down. Do we have any other raised hands?
I do.
Okay, go ahead, Karen. That's right, you do.
You mentioned fall prevention, and it seems like whenever we read or take a class about fall prevention and they talk about the importance of preventing a fall that would break your hip, they always say that there's a much greater chance of a person dying within a short amount of time if they break a hip. And I've never really understood why that is. Anybody have insight into that?
Well, my husband had a hip fracture. He fell. He's a tall, thin, healthy guy, fell and broke the hip. And I can at least tell you what they told me in the hospital, which is, one is the outcomes of anesthesia. In his case, he was pinned back together. And he's a tall guy, he's 6'4". And I found after the fact, the pin they put in his hip to pin back together is 17 inches long and made of titanium. I about passed out when they told me that. Because first of all, I kind of wanted to see what in the world type of equipment did they use to put that type of pin down a person's femur. Other people may get a hip replacement as a result of the fall. A lot of it, I understand, comes to anesthesia and the literal stress on the body of coming out of a hip fracture. But I open up, and that's what I was told at the hospital and what to watch for. It is a phenomenally stressful impact on the human body going through the recovery from a hip fracture. It's staggering. Even on a very healthy person like my husband at the time, he went into a nursing home and rehab was slow. Anyone else want to add to the hip fracture discussion? It's a great question. Okay. Nancy?
Yeah, Nancy here. You're probably going to be immobilized for quite a while, or relatively immobilized. That's going to have consequences. You're maybe going to fall into some isolation. Just a cascade of things can start to go downhill from that. You may not eat as well. You may simply be checked for other conditions, and they'll start you on another medication or 2 or 3, and those will have side effects.
Yep. And my poor husband was in a nursing home during COVID, no less. So add to that the risk of exposure in a nursing home, which I think if you need institutionalized living and you have not been in one, that itself adds an element of risk. Yeah, great points, Nancy. Thank you. All right, the part that remains is very small, and but it forms a foundation of criteria for making financial decision choices. That will be, it would be good to understand it and to think about at the end. I'll give you some closing questions, because when we get to the part of the class where we talk about forming our end-of-life documents or estate planning documents, these types of issues need to be well understood by you, because they sort of found the foundation of a financial plan. So I'm going to head back to the presentation. Again, much shorter, not much remains. Okay. There are some words people use in the financial world that underpin a lot of the choices we have discussed and will discuss. So we've, I think, beaten down all I plan to do on caregiving and health, but by talking about joint longevity tables, you now see that the potential of long-term care may be higher than you originally thought. The other thing we talk about are broken safety nets. So you have great plans for how you want to live your life, but something happens that you can't stay where you thought you were. Your disability needs, a lack of transportation affects you so that you can't stay there, or your cognitive decline means that you need to live in a different place. So we'll call that the broken safety net. Liquidity. This is something I don't hear talked about often enough, and yet it pervades our life. So let's imagine that you really do decide that you would like to live in a continuous care facility. Okay, and fortunately, you are living off a Social Security check and perhaps a pension check, or maybe regular RMD distributions from a modest savings account. Ponying up that amount of money for the buy-in is a one-time event that may have it may be hard. You may have to sell your home, but that in turn may yield a huge capital gain impact that is going to result in a large set of taxes because you're not rolling into another home, though that's not a different issue now than it used to be about 10 years ago. Or you have to pull a lot of money out of an IRA, and so now you have high income for the year, which 2 years from now is going to jack you up into a much higher IRMA rate on top of your Medicare payments. In other words, these things are just totally entwined. The tax consequences, the Medicare consequences, but simply having the cash available is what we call liquidity. You might get in an accident, for example, and you need a mobility device, and you want one that provides far more features than what you can get from Medicare. So you might need to pony up $6,000 for a special bariatric scooter, for example. And that may not be money that you have on hand. Or you might be living in an active 55 plus location, and buildings are getting older, and then all of a sudden one day you're hit with a really large special assessment. These types of things happen. So that's a liquidity issue where the sudden surge in costs does not align with how your money's coming in. An inflation issue is, I think, what they call the senior's worst nightmare, right? That's what we all worry about, is the cost of goods going up. So this is not a liquidity event. This is the fact that everything is costing more, and it just seems to be relentlessly increasing in price. So the question becomes, can I even keep up with that? It's the rare American who has a pension plan that is inflation adjusted. In fact, for most people, the only inflation adjusted asset they have is Social Security. Why is it inflation adjusted? Because it has a cost of living adjustment built into it. Now, we can argue whether or not that cost of living adjustment aligns well with the inflation that you're experiencing in your life, your personal inflation rate. But inflation is the bugaboo of all seniors. Okay, so we're not earning salaries anymore, or if we are, it's not nearly as much as we used to make. And so inflation now has become a huge driver of how we spend down our money. The other risk I beat to death earlier was the longevity risk, because 18% of us will live to a ripe old age. And the legacy is, some people have such a strong sense of purpose that giving to a particular charitable cause, giving to a nonprofit, or leaving to their children, or taking care of someone with special needs becomes an overwhelming objective. They will make lifestyle decisions to preserve their capital at all costs because they have legacy considerations. So let's remember those as goals that we need to manage. We'd like to be able to have cash when we need it. We'd like to be able to keep up with inflation. We'd like to live a long time and have enough money for it. And we'd like to leave a legacy. So if those are all goals, we can build a chart that looks like this. There are the population I'm leaving out is the population that is struggling mightily, because it deserves its own briefing. So this particular course assumes that you have enough assets to be able to live independently, even if you have to downsize or live in a small apartment. Because when you get into situations where you need more public services and help, it deserves its own time, and the decision criteria you make for that are different than I'm going to present in this briefing. So I apologize, I can't go into that. But for example, Medicaid planning and shielding of assets, and public services that are available to you, SSI and other things that may be available to you, I can't go into that in this briefing. So this is outside of that, assuming that you have the assets necessary to live independently now. Your assets may come in different forms. We have what I call safe assets, reliable assets. These would be Social Security, pensions, income annuities, not fancy exotic variants of indexed annuities, but simple annuities or deferred annuities, or bond ladders. Now, what is a bond? A bond ladder can be something as simple as you buying treasury notes or treasury bills that mature every so often. Maybe you buy bills that mature. You keep all your money in T-bills, but you have treasury notes that mature every 2 years, giving you a wad of cash you can live off of. And you just buy these. The interest rates are good when you buy them, and so you buy them to span a period of time. Quite a lot of people use bond ladders for a portion or all of their portfolio. Now, diversified portfolio is what most people under of working age and younger being told to build up. So let's say you're a person and maybe your spouse worked and you put all your money into a 401k as much as you could, did pretty well. We were kind of lucky once we got out of the 2008 crisis. You know, there's been some serious pullbacks, but there's also been some real boom times for those who had a number of equities. And probably your portfolio did pretty well. So we're not going to go into what type of portfolio gives you the best return and whether or not it should be 60% bonds, or that's a discussion for another briefing by a qualified fiduciary and financial advisor. But some people have almost everything in a diversified portfolio. In other words, they just saved all their life. It's sitting there in a 401k. They rolled it over to an IRA maybe, and they're just going to pull 3.5%, 4% from it year after year after year and let it grow, and the legacy will be whatever the legacy is. However much is left at the end, you know, you'll see if you make it through. But that's the diversified portfolio. That's called a probabilistic way of living. Why? Because you truly are depending on market conditions for the equity or portion of your portfolio. It is a risk-based portfolio, but if you have enough money, theory says, Bengen's rule, if you have enough money, you can withdraw up to 4%. Now, that rule hasn't been the same in all countries, and there's even some question about that today in times of high inflation. But again, many people live off a portfolio. Then other people have reserves. You can sell your house. You can have an insurance policy on the first to die. You can have an insurance policy on the second to die to meet your legacy needs. You can have a family safety net. But this is what you need to think about. What is your situation like? I've already said, I call them two camps, the safe camp and the probabilistic income camp. That doesn't mean that living off stocks and bonds is any less safe. I'm just giving it a different name because it depends on market risk premiums. So let's look at this. Everybody here probably falls into one of these, excuse me, much more than the other. So this is a chart where the top part of the chart says you've built a portfolio that gives you some buckets of cash when you need it. May not be very big buckets, or it might be huge buckets, but you have the ability to get liquidity. Okay, you have options for liquidity. The bottom part of the chart means you've got extra income coming in over time. And I'm going to give you some real world examples, and when we go through them, you'll probably figure out where you reside. The left part of the chart means you depend more on a safety first portfolio, treasuries, bonds, fixed income, pensions, annuities. The right side of the charts means you're more market driven. So let's go down through some real world examples, because this foundation and presentation for retirement income is extremely standard in the industry. And if you go see an advisor, they're going to talk to you in this language. Okay. The first would be safety first. You just live off Social Security, maybe a small pension. The next one is, well, you do that, but you have some bonds or CDs that are mature in the early part of retirement to help you get to maybe full retirement age or till you start Medicare. So that's very common to have assets to bridge you into retirement. Another one might be, well, you know what? I'm doing just fine. I can live well within my Social Security and my pension or whatever my other safe assets are, but I'm a little bit concerned I might run out of money when I get into my later years. So I'm going to buy a deferred annuity that will only kick in if I reach 80 years old. Okay, and they exist, and some of them are even specially tailored so that if you don't make it to 80 years old, not all of your money's lost, some will go to a beneficiary. But that's what a deferred annuity is. It's to reduce longevity risk. The next one might be, you know what? I'm doing okay with our safe income, but I'm really concerned about what will happen. I think it's going to be a little lean when my spouse dies. So you might have a first to die joint life insurance policy. That's a bucket of money that only comes in when the first person dies. Another one might be, you know what? I know for sure our quality of life demands that we have this small secondary condo or small vacation home somewhere. We like to do things, and in 5 years, we want to know we can go to this other place and enjoy our life. So you might have a multi-year guaranteed annuity, which is a CD-like product from an insurance company. Again, guaranteed return, you know exactly what it is when you buy it, and it'll hold your funds, and all the interest that you earn on it is tax deferred until it comes time to buy that vacation home. That's why you did it instead of letting it sit in the bank. These are all examples of time segmentation strategies to give you cash when you need it. And I know I've focused on senior living a lot, but there's a lot of things that make life fun that you want to plan for that you need to have cash available when you need it. Here are the strategies that are built on top of the safe strategy, but extra income. So these are not time bucket strategies. You're now in number 3, category 3 on that chart. You live off your Social Security and pension, but you do have a 401k and you pull it a 3% withdrawal rate, or you take the required RMDs. That's all you do. You take it. You may spend it. You may not. But you know what? You have a cushion. You have a cushion on top of that safe income. That's a very common one for a lot of people who are more recently retired. Another one is that you have safety first, but you are terribly worried about inflation. So what you do is you take a portion of that money you saved when you worked and you buy out Treasury inflation protected securities, TIPS. And you buy a bond, one to mature every year for the next 20 years, so that a portion of what you're going to live off of is completely inflation adjusted. And if any of you don't know what this is, I'm going to cover it a little later, but they are earning actually 2.3% yields on top of inflation right now. Treasury inflation protected bonds. So they're AAA rated products from the United States Treasury. Another one may be that you buy a simple annuity, single premium immediate annuity to provide you with an extra $600 a month. Why would you do that? Well, it may be you are able to, through something called mortality credits, get a better rate on your money safely and provide you with extra income. And you don't want to be invested in the stock market. Maybe that's why you do that. But it gives you extra income on top of your safe portfolio. And as we come to the end, here's numbers 2 and 4. Number 2, this is people who live off a probabilistic portfolio. Maybe they hold stocks, bonds, real estate investment trusts, but they also want some time segmentation. So they too can buy I bonds or CDs or a deferred annuity or one of these other products to do things like buy an RV or fund a move to another area. So they've handled their income and their time segmentation risk, the fact that they need liquid cash. Okay, and number 4 is the last one. This one is a probably where some of those with greatest wealth may be in here. These are people who may not only have a diversified portfolio, but they've placed extra money into private equity, other investments for legacy or charitable distributions. They may have a donor fund to support their favorite charities. These are things to handle those legacy considerations. They too may use inflation protected assets, immediate annuities, or even a rolling set of treasury bills, which you can do at Treasury Direct. You can start with $25 and you just start rolling T-bills because you get better returns than you do sitting in a money market account at a bank. Although there's some pretty good money market accounts out there, I must say. So as we go forward, think about where you stand with how you're financially postured against these goals that we talked about. Inflation. Are you inflation resilient? Are you resilient to your own longevity risks? Are you resilient in getting cash when you need it? Can you handle cash liquidity needs? And then do you have any other special legacy needs, a child with special needs, for example? Because the risk zone from the perspective of those who will be looking at your financial profile if you want to move into assisted living, or your fiduciary, they will be looking at you as you save up and then as you spend down. You know, you may not spend down to zero. Hopefully you won't, but that's what they do for business. So in the next class, we'll build on top of this and move into important financial milestones, Social Security planning overview, including we'll talk about the transition from employer-paid plans into Medicare Advantage Drug Part D plans. Show you some online tools, not only for that. Somebody requested some interesting tools for handling the banking arrangements, budgeting tools. We'll talk about that. We'll talk about inflation risks and a bit more about these types of safe assets and spend down plans. So I am going to stop presenting. And I hope that that financial part wasn't too dry, but I think thinking about financial risks is important in light of the other decisions we may encounter as we age. Any questions? Yes, John.
And those charts that kept on saying until you're age 80, was that, or is there a reason why it said until 80 and not a higher age?
No, I was just picking, I was trying to translate that very abstract chart into questions a typical person might have. No, so that was just because I was imagining being someone who wanted money at age 80 for that. Yep, no particular reason.
Okay, thanks.
Yep, just an illustrative example. Anyone else? All right. I hope that was useful. So, okay. All right. Well, then I will see you next week. I'll send out the slide information like I did before. You can unmute yourself if you have anything else you want to ask or anything you want to follow up on what was presented today. All right, then. I don't see any other hands. John, any further questions? Okay. All right. Well, have a great afternoon.
Thank
Bye.
you.